Hello, and welcome to the 15th annual Sue MacRae Lecture on Ethics and Patient-Centered Care. My name is Jennifer Gibson. I'm the director of the University of Toronto Joint Centre for Bioethics, and it's my pleasure to be moderating today's seminar. Today's seminar, entitled Sexual and Gender Diversity in Cancer Care, the PMChosenFamily program, is being presented by Dr. Christian Schulz-Quach, with co-presenters Margot Kennedy and Brendan Liver, and I will come back and introduce each of them in just a moment. But before we begin today's gathering, I do want to open this in a good way by acknowledging this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work, learn, and engage with each other on this land. The Sue MacRae Lecture on Ethics and Patient Care aims to explore the felt ethical experience of those who are sick or unwell, perhaps in the relationship to themselves, family members, caregivers, and/or systems of care. The goal is to understand how patient-centered or relationship-centered frameworks and best practices, inclusive of patient and/or family perspectives, can help illuminate and address bioethical problems. Sue MacRae, for whom the lecture is named, played an integral leadership role in all elements of the Joint Centre for Bioethics mission as its deputy director from 2001 until 2007. She is and has been a champion of patient-centered ethics, an innovator in building ethics capacity, and a leader in bioethics scholarship and education. Sue was instrumental in creating a strong community of practice at the Joint Centre for Bioethics and played a key role nationally as the president of the Canadian Bioethics Society. We are honored to have Sue MacRae with us today. She has graciously agreed to say a few words about this important annual lecture. Sue, welcome and welcome back. Thank you for joining us, and over to you.
Thanks so much, Jen, and really a thanks to the Joint Centre for Bioethics for honoring this topic and this work on in an ongoing way year to year. It's incredible to see that we're at 15 years. It's incredible, and also thanks to Terry, who I know has been a big part of organizing all the logistics. Christian, Margot, Brendan, I'm so excited to hear your talk today. This topic of sexual and gender diversity is so timely and crucial and honoring of the Sue MacRae Lecture that really, as Jen said, aims to really understand the lived experience of individuals receiving healthcare and how that impacts ethics. And I think that's an interesting intersection. And speaking of intersections, I'm so looking forward to the intersectional lens to the topic that you're providing today and learning from all of you. Interestingly enough, I'll just say this little aside that this is a bit of a full circle for me, since my own research in ethics and patient-centered care actually was a small pilot study that I did with a cancer patient, looking at their perceptions of ethical issues back in like 2002. So it's really interesting to come back full circle to cancer care in that way. So thank you for doing this important work and for sharing it with us today.
Thanks so much, Sue. The Joint Centre for Bioethics seminar series and today's lecture provides a forum for exploring bioethical issues in contemporary health systems and settings. It seeks to engage a range of topics and speakers from a diversity of perspectives to foster curiosity and understanding through respectful dialogue, particularly around complex and nuanced topics around which there may be different points of view. And so this leads me into the format of today's lecture. We will start with a presentation by our presenters, followed by a moderated discussion period. Please note that today's lecture is being recorded, and you will be able to access the recording along with other archived JCB seminars on the JCB's YouTube channel. During the discussion period, you are invited to pose a question. through the YouTube chat function or to send your question via email to jcb.ea@utoronto.ca. As questions come in, questions will be grouped by theme and summarized to ensure as many questions can be addressed during our time together. Now it is my pleasure to introduce today's speakers and really get to the main event, which is to hear from our speakers. Christian Schulz-Quach is an assistant professor and clinician educator in the Department of Psychiatry at the University of Toronto and a staff psychiatrist at the Princess Margaret Cancer Centre and the Centre for Mental Health at the University Health Network. And this has been since November 2019. He completed his medical doctorate in neuroscience at the Wittenberg University in Germany and holds a Master of Science in Palliative Care from King's College London and a Master of Arts in Existential Phenomenological Psychotherapy from Middlesex University in the UK. Christian is board certified in psychosomatic medicine, medical psychotherapy, and palliative medicine in Germany, and is a member of the Royal College of Psychiatrists in the United Kingdom, as well as being on the board of directors of the Canadian Academy for Consultation and Liaison Psychiatry. He has specialist psychotherapy training in psychodynamic psychotherapy, gender, sex, and relationship diversity psychotherapy, dialectical behavioral therapy for post-traumatic stress disorder, and dignity therapy for end-of-life psychotherapy. He is the director and co-founder of the Sexual and Gender Diversity Program in Cancer Care at Princess Margaret, and proud to work with an amazing team of courageous colleagues, two of whom I believe are joining us today. Next, I'm pleased to introduce Margot Kennedy, who co-founded the Sexual and Gender Diversity Program in Cancer Care at Princess Margaret Cancer Centre at the University Health Network in 2020, and is the clinical lead of this program, which is now running in its 4th year. Congratulations. She brings 32 years of experience to her role in clinical social work. She holds a Master of Social Work from the University of Toronto and is driven by her passion for health equity issues. Her extensive experience in cancer care has provided a deep appreciation for the many stresses, barriers, and challenges that cancer patients may encounter, especially related to intersectional identities. Margot loves helping people to find their strengths, pride, and superpowers. I love that. And Brendan Lever is a research analyst for the Sexual and Gender Diversity in Cancer Care program at Princess Margaret Hospital and the Department of Security Operations at the University Health Network. Brendan is currently completing his master's degree at King's College London in the United Kingdom, where he is studying psychology and neuroscience and mental health. He received his honors Bachelor of Science at the University of Toronto, where he specialized in neuroscience. His research interests include quality improvement in healthcare, health equity, inclusive care, and trauma-informed approaches to healthcare. And so, without further ado, Christian, Margot, and Brendan, on behalf of all of us, the Joint Center for Bioethics, and others joining us online, welcome to today's seminar, and I will hand it over to you.
Thank you so very much. Thank you, Dr. Gibson. Thank you, Sue MacRae. It is a real pleasure being here together with my colleagues, Margot and Brendan. And also a big hello to everyone out there. We do know that some of our friends from across Canada and some of our friends internationally from the UK and Germany are chiming in and sitting here in front of their screens. And so we say hello to everyone and hello to Deutschland. And while we are starting today, we want to make sure that we frame it in a way where we really will hopefully make it clear to you that we don't have all the answers, but certainly have a certain pathway that we want to share with you that we have walked on over the last 3 years. So we'll go to the next slide, and I just want to give you a quick update on our conflicts of interest. They are here on the slide, and you can look at them. I will not talk about every single point, but none of them are severe conflicts, and Margot and Brendan have none to declare. Margot, over to you.
Thank you. So hello, everybody. It's such a pleasure to be here. So we wanted to start off today just by making a really clear statement that during our presentation, we want to make a very shared commitment to create an inclusive and safe space together to learn from each other, be curious, take risks, and ask questions respectfully. We'd also like to take responsibility for any unconscious bias and to respectfully challenge ourselves and others if this comes up. And we want this to be a space over the next hour and a half where nobody's being judged, nobody's identities are being judged. And as Kristen mentioned, we come to this work, I think, from a place of being very passionate and very committed, but also very humble. And I know in my social work education, this wasn't an area that I had any sort of training or learning around. So many of us are just coming to this from a place of being sort of very new and wanting to do the very best they can to serve the patients they work with. And I must say, every day I learn from patients so much. You know, a quick example is from a trans man patient who I've been working with, who's recovering from ovarian cancer. And we met the day before he was going to start a cancer exercise group. And he realized, like, oh no, what am I going to do if somebody asks me what kind of cancer I had? What am I going to say? So, you know, he's someone who identifies as a man with a beard, and he was really sort of concerned about judgments people might make when he shared that he was treated for ovarian cancer. So that was something that never occurred to me, and I was just sort of stunned. And, you know, every day I just continue to learn and learn and learn.
Thanks so much, Margot. And just adding on to that, we really want to emphasize our priorities, starting with safety. Just for background, so I joined this group 3 years ago this June, and it's been amazing seeing how much this group has grown. And you can see the list of a whole bunch of amazing people, from clinicians, researchers, and so on. And one thing that's always remained the same is how much we all emphasize and care about safety in this group. And we want to bring that to this group today.
Safety is one of our core principles, but we are also focusing on collaboration. And so you see here a little map of Canada. That is our main nation we're focusing on. And we wanted to show you the different provinces that we are working with, and want to really send a shout out to our colleagues who are collaborators on a daily basis. First and foremost, we want to speak to the pioneers of talking about queering cancer. The two co-founders, and there are more co-founders, but the two co-founders, Amanda Balderston and Kim, who have been extremely proliferate in really producing an online network that talks about, educates, and provides resources around queering cancer. Tristan, Jackie, Gila, and Marianne are other wonderful collaborators we're working with. And what we're trying to say here is that we're right now, today, really representing a large group, a network of people who work together in the sense of a, if you will, chosen family, where not always everything is not rocky, but it always feels very safe to speak to each other about what's rocking our boat. So now to the talk. We wanted to talk to you about what actually is, from our perspective, the foundation of inclusive care. What are the principles that are relevant from a clinical ethics perspective, but also from a perspective of day-to-day care? Then why do we need SGDC, so sexual and gender diversity in cancer care? Because that's a question we encounter on a regular basis. People ask us, why do we need your work? Why is it important? Why do we still need it in 2024? We want to talk about the specific experience of patients with a sexual and gender diverse background at the Princess Margaret Cancer Center, and how we've tried to really hone in on their experiences to understand how we would shape our program and our programming. And then we would like to talk about how we can meet these needs specifically by way of interventions.
Wonderful, thanks. So There's a few different theories, theoretical approaches that we bring to our work with patients that we found to be quite helpful. So the first one is called the minority stress model, and some of you may be familiar with this theory. It's been around for quite some time now. So this theory really looks at the impact of stigma, prejudice, and discrimination that's faced by folks in the 2S LGBTQIA+ community. Does everyone know what that acronym stands for? Two-spirit, lesbian, gay, bisexual, trans, queer, intersex, asexual, plus other identities that aren't named in the acronym. Can be a little bit of a mouthful to say. That's why we kind of like our sexual and gender diversity language. So back to minority stress. So this is a theory that really speaks to people developing defensive coping mechanisms that are very protective, but also take their toll in terms of anticipatory stress and just sort of preparing for experiencing something negative, like a microaggression, like discrimination, like being excluded. The theory talks about distal factors, which are factors on the outside, such as discrimination, rejection, and exclusion, as well as proximal factors, such as negative expectations. So this can impact physical and mental health to a great degree. And I think one of the really helpful things about this theory too is how it understands too that community connection and pride in one's identity can be really key important factors in mitigating different stresses that occur. So this is certainly one model that we bring to our work with patients.
Another theory we want to talk about was the intersectional identities theory. So intersectional identities just looks at the different parts that make up who a person is, from their age, sexual orientation, their gender, their background, their heritage, the language they speak, and so many different aspects that come together to make a person who they are. But these different aspects can contribute to whether a person receives certain privileges or certain stigmas and gets excluded from certain things in society due to these different aspects that make up who they are. A very important story I remember speaking with a patient's caregiver was they were receiving some very poor care at Princess Margaret, and they didn't really know why. And the patient said, I don't know if we're receiving poor care because we're women, because we're Black lesbian women, all these different parts of their identities that have sort of hindered their experience in cancer care, unfortunately.
Now, as we're talking about these topics, we want to be very clear that we're proud of working where we're working and being part of the University Health Network. But we also want to address those gaps, which, my apologies, those gaps that need to be addressed so that we can become more inclusive and that can we diversify the experience of lived cancer care in our wonderful center. So the basic and most important starting point is on the right-hand side that we're basing, like many IDEA programs, everything we think about from a social justice perspective. We at the Sexual and Gender Diversity in Cancer Care program have 4 pillars on which we're basing the majority of our work. Those are pronouns work, around understanding better, educating, and helping people to express their pronouns in a helpful clinical care setting way. We talk about gender identity and how this is relevant and how it is different from the 3rd pillar, the sexual orientation pillar. And then we have a 4th pillar, which was an important one for us to add from the beginning, and that is the one of relationship diversity, because relationship diversity is an aspect that can, particularly when care becomes intense, when we're talking about ICU, emergency departments, or end-of-life care, a very, very important and emotive component of good care. Sometimes in these situations of care, when we're not yet meeting our full potential of inclusivity and diversity acknowledgement, we can sometimes feel like there is an invisible barrier. There is a sense of we cannot break through. We might feel silenced, or we might feel silence. We might not feel that we can address what we think we should address because we're second guessing ourselves, because we think that maybe it's not okay for me to bring up that I feel uncomfortable, or that I feel judged or labeled, or that I feel that someone has put their assumptions and unconscious biases on me. Can I push back? Can I actually also maybe ask for clarification, although I'm dependent on this clinical care? This is what we talk about when we talk about the power of oppression, and how sometimes in our healthcare system, we still feel we need to educate people around the impact of historical harm to some of the marginalized communities that we stand for and try to speak for. Just past weekend, I had an opportunity to revisit one of the famous documentaries of the 80s and early 90s, HIV and AIDS crisis in New York. And it really brought to the fore and reminded me of how important it was that people did speak up, even in situations that they felt unsafe. They felt actually unable to fully express their concerns in well-labeled sentences yet, but they did not give in and were activists who eventually actually changed the history of how we approached the AIDS crisis and later on HIV treatment. So that's the foundation we work on, and we'll move on to the next slide. I want to also send a shout out to our colleagues in the UK, mainly represented by Dominic Davies on the lower right end here, who is an absolute international pioneer in gender, sex, and relationship diversity therapy. Dominic has founded an organization, Pink Therapy, for which you find a QR code here on our slide, which is now an internationally leading organization for training gender, sex, and relationship diverse colleagues in providing care and therapy for patients who require it. They just recently came out with 7 core components of what it actually means to provide gender, sex, and relationship diversity therapy. And we in our program are very much aligning ourselves with these 7 components because we feel that they're crucial to understanding the diversity work that we're trying to propose, and also the ethical principles underlying our work. Fostering joy is a very important one. We sometimes are a little bit embarrassed and maybe also awkward about bringing up topics that feel like we are blaming and shaming, which of course is absolutely not our intent. But we do sometimes need to bring up difficulties in the healthcare system on behalf of others who don't have as much of a voice as we do. And so fostering joy means that we also want to talk about the positive examples. We want to talk about where care went well and get in the right direction, as well as where we actually see that our minority groups that we represent and identify with ourselves actually have strength and have advantages over others that we have found in the literature. We want to adhere to a practicing of commitment to social justice, just as I had explained in the slide before. And we want to also make sure that we're demonstrating cultural humility and cultural competence. We're emphasizing both humility, the willingness to really reflect upon our own unconscious biases and our own assumptions, but also competence, meaning that we don't leave the teaching aspect to those who come to us from a different background or feeling that they have something to share with us from a different cultural perspective, but that we're taking proactive steps of actually educating ourselves. We expect from a GSRD therapist that they have knowledge around contemporary sexology so that we fully understand how to communicate and which words should be used. And we want to also acknowledge the understanding that's specific to avert adverse effects of oppression, as I just discussed. Finally, and that's important for our work here at Princess Margaret as well, is that we need to be trauma, grief, and shame informed so that we truly understand how certain behaviors and responsive behaviors can sometimes be an expression of utter despair. Next slide.
Great. So as Christian was saying, one of the things that we sort of get asked quite a bit is the whole question around, what exactly does this have to do with cancer? Why do we need a program like this? And how is a cancer experience different for SGDC folks? So the next slide shows a little diagram of a patient walking in our door. And, just in a very simplistic way, we could provide you with endless slides of stats and data and studies that show all of the many cancer care disparities right across every sort of point of the cancer care continuum. But another way to look at it, which I think is equally powerful, is that emotional experience and those questions that patients bring when they walk in our doors. Should I come out to my healthcare providers? If they misgender me or if they make a wrong assumption that I'm straight, should I correct them or just leave it? Will this impact the care that I receive? Is this going to interfere with my hormone replacement therapy? Or can I still take PrEP, being on chemotherapy and getting radiation? Am I going to be the only queer person in a support group? Are there resources that are going to meet my needs? Will my chosen family be included? Very importantly, will there be all gender washrooms at the hospital? Because that's a place where a lot of trans folks experience violence. What if I experience discrimination? What if I don't get, the care, the same care that everyone gets because of homophobia? So those are some big questions that can weigh very heavily. And if it's not already stressful enough to walk in the doors on your first visit to a cancer center, adding a lot of these extra layers can just make it extra difficult and extra challenging. And so a part of providing inclusive care isn't the treating all patients the same. It's really looking at the unique questions and experiences and concerns that patients bring when they come through our doors. And being very aware of biases and being very thoughtful in how we ask questions. So another example I can think of with a patient, this is the same patient who I used on the first slide, who's a trans man. His first appointment at the gynecology clinic was being called by the name on his health card, which is his legal name, but it's not the name that he uses any longer. So in a waiting room full of women waiting to see the gynecology team, this patient, has to stand up and sort of walk across to the nurse. And the nurse looks rather confused when she meets the patient and says, "Oh, is your wife in the washroom?" And, how humiliating for the patient. He just, handled it with such grace and said, "Nope, that's me. You probably weren't expecting someone that looks like a guy with a beard, but I am your patient. Here I am." And I'm sure the nurse was like very mortified as well, because healthcare providers, I think, generally want to be inclusive and do a really good job. But sometimes our biases catch up with us. So that's just sort of an experience of what it's like for some of the patients who are coming. And this is just a little snapshot. And certainly the SGD community is such a beautiful, diverse community, communities that, we really want to include everyone's experiences. It's sort of very difficult to capture it all on these little wee slides.
Thanks so much, Margot. And just adding on to that, we've heard so many amazing patient stories over the year. And one patient in particular, Ross, actually volunteered a couple Pride months ago to share a bit of his story, which we'd like to share with you all today.
Erased. As a gay man going to Princess Margaret, I got the feeling it was homophobic. There just didn't seem to be any language ever used, whether I was asked whether I had a partner or not, or a best friend. And the majority of the group that I saw there were couples, were men and women. I didn't see a gay couple. I can't be the only gay person. So he really felt alone.
So feeling alone speaks a little bit to the aspect of oppression that we had mentioned before, which can be a general tendency in healthcare settings where siloing and the bridging of siloing so siloing happens, and bridging siloing is a very difficult procedure, sometimes doesn't work. What we noticed in a recent work by our first postdoctoral fellow in the SGDC program, Amanda Bolsesem, together with our colleague Lauren Squares, is that we also have to look at how actually sexual and gender diverse providers of care in cancer centers feel. There's a piece of research that we've done together with them in a qualitative research piece where we looked at the experience of healthcare providers specifically on whether they come out to colleagues and patients and whether they have any concerns about doing so, and if so, why. There is indeed a perception that doing cancer care and working in a cancer care environment can sometimes feel as if there is a very strong cis heteronormativity assumption in most of the work that we're doing. Can sometimes feel like, for example, presenting a patient as a 34-year-old female is the norm, which is a very binary way of thinking about patients. But at the same time, there's also, of course, an acknowledgement that there's sometimes, from a biological and gene disposition perspective, there is a need to identify a sex because it will help identifying which treatment plan we can follow. So for many healthcare providers, there is a bit of a conundrum that they face. We know that a huge amount of providers really want to educate themselves. They want to learn and understand more about how they can communicate more effectively about pronouns, gender identity, sexual orientation, relationship diversity, but they feel that they haven't really been provided with the right type of guidance. An opportunity here. On the other hand, there are healthcare providers who do self-identify like ourselves, Margot and myself, who self-identify quite proudly as being part of the queer community, but also realize that there are many, many more in the cancer care system who don't feel so comfortable about articulating their identity. We did a little bit of a deeper dive in why that is so. And we also found that some people make a very, very conscious decision of not wanting to come out for reasons that have to do with not wanting to marginalize themselves more by feeling forced to come out, or by feeling that it actually truly, for their perspective, has nothing to do with their work. A vast majority of colleagues, however, felt that they just didn't feel that they had safe enough space to articulate their insecurities and their ambivalences, and that they just needed a safe community of practice and a safe community of chosen family to feel that they could come out. And that's what we created. So now we're going to talk to you a little bit more about not just the healthcare providers, but actually our patients. So what's the experience of SGDC patients at the Princess Margaret Cancer Center, and how did we approach this in our own work over the past 3 years? To frame this a little bit, as this is an academic presentation at the Yale University, we are going to talk in 2 slides only about a few methodologies. And one methodology that we've applied in trying to approach how we can actually create a program around sexual and gender diversity in cancer care is the SEEPS model. SEEPS is the Systems Engineering Initiative for Patient Safety, which is a framework or methodology which guides how you approach a problem from a quality improvement perspective. SEEPS is a methodology or a framework that has been updated multiple times. We are using 3.0, it's the most recent one. And it also comes along with an extra toolbox of very specific instruments or ways of how to enact quality improvement steps. That's the SEEPS 101 toolbox. Here's a little overview of how we're actually applying this. So when we look at the patient on the central timeline in the middle, the patient who comes to our Center for Excellence in Cancer Care does not have a single point of contact and one singular event that they experience on their patient journey, but they actually, if you draw a journey map, are going through several moments of contact and encounter that are all influenced by a complexity of phenomena. SEEPS differentiates and distinguishes between, for each of these encounters of interest, between four main directions: tasks, tools and technologies, physical environments, and organizational conditions, all of which influence how a patient feels in a given situation. For example, as a queer patient coming into a cancer center for a screening program. The outcomes that we will be focusing on are not just focused on the patient alone, but they're focused on the unit of care, including the caregivers and chosen family members, including clinicians, staffs, learners, and volunteers who are involved in the experience. Some of them we're going to talk about. And of course, it also relates to the healthcare organization and the culture the healthcare organization is promoting. We can ask with SEEPS which parts of this diagram we need to shift so that we can change organizational culture.
So we started with a top-down approach, just looking at what's currently available in the literature. This is a bit of a unique process, actually, because there's a lot of information out there on cancer care and survivorship. There's a lot of information on sexual and gender diversity and in healthcare. But looking specifically at sexual and gender diversity in cancer care can be a little more unique and more challenging. We found many themes such as emerging emphasis on intersectional identities, specific psychosocial disparities experienced by SGDC patients, specific quality of life impacts of survivorship in SGDC patients, recommendations for improving inclusive care. And one of the biggest ones we really want to highlight was the salutogenic factors identified in SGDC patients. There's so much in the literature about how strong these patients are and how strong the community is and how much of an impact that actually made on their cancer care experience. Specifically, we found a paper looking at heterosexual couples versus lesbian couples, and it really showed how lesbian couples really supported each other more through the process and actually became stronger in their relationships versus other sexualities. As well, just due to the strength of the community and the whole idea of chosen family, a lot of patients reported that they felt a lot of support from the people around them while they're going through these experiences.
Great. So I myself am a social worker. I don't call myself a researcher. Sometimes I have to admit I can find research just a little bit intimidating. But it was a wonderful opportunity to work on this quality improvement project, this needs assessment, where Brendan interviewed 21 patients. And it was just like reading a beautiful novel. It was just sort of fantastic, sort of reading all of the interview transcripts. We took the first 10 interviews and did a little preliminary analysis. So that's what this little poster is sharing. And we're so appreciative to the talents of Emily and Lux in their beautiful sort of graphic design in using graphic medicine to depict some of the preliminary results from the needs assessment. So I thought today I would just talk about sort of two themes that we uncovered. So the first one, we're going into the middle to the left-hand side, and it was a theme of protective non-disclosure or protective concealment. So this was a theme that really addressed patients coming into a cancer center and really feeling that they can take their sexual orientation and gender identity and expression, their SOGI, almost like a suitcase, and just sort of check that at the door and then walk into the hospital and have this very important part of their identities to be completely left behind at the entrance. And this was sort of reflected in, assumptions, mistaken assumptions of being straight, of a partner being just sort of a friend or a sister or whatever. Never being asked about sexual orientation and gender expression, but then also telling us, well, but I didn't sort of offer it up either. So really taking on responsibility as a patient that that's something that they should correct staff or be sort of really out about to staff with. And then this was another quote. It says, if there was an atmosphere from the very beginning about inclusiveness, then maybe I would have felt differently. Maybe it would have been more important. So a lot of really sort of important sort of comments and experience under that theme. The next theme in the middle, I love this sort of image. So this is a patient looking through a window of a restaurant serving a beautiful buffet. So some of our patients, many of our patients, had a really difficult time trying to articulate what exactly does inclusive care look like to you? What does it mean to you? And it's really it's hard to answer that question when it's hard to imagine what's on the menu when you've never been invited to the table. So many patients told us sort of what their experience, what inclusive care didn't feel like, and then sort of inferred what inclusive care might look like. And they provided sort of really valuable feedback and quotes that we'll be able to take and integrate further into our program development. Oh, this is me again. So in terms of our work in meeting the needs of our patients, one of the things that Christian sort of alluded to in the SEEPS model was starting off with environmental indicators. So we got these chosen family lanyards made, 2,000 of them, and pronoun buttons. One of our patients has a pronoun business, and she makes these adorable pronoun buttons. So we were able to order 2,000 pronoun buttons from her. And over again in our quality improvement project, we heard how important this is for patients. That the smallest thing like a rainbow lanyard or a pronoun button or staff members starting off interactions by introducing themselves with their pronouns seem to have such a profound impact on patients and was such an important signifier that, maybe this person could be safe. Maybe this person does provide inclusive cancer care. Maybe this person will be okay to be who I am and they'll accept me. So incredibly important how simple something like that can be. Another environmental factor was introducing 7 all-gender washrooms on the main floor of the hospital, switching out the sort of typical, I don't know what to call them, sort of signs of, male and female little stick figures, to changing it to an image of a toilet and to the wording that says all gender washrooms. So that way a patient who maybe doesn't identify either as male or female knows there's a toilet behind that door and this is a safe, welcome space that they're free to use. Also Pride Month, it has been sort of a really important sort of event where we can do lots of sort of promotion and really be out there full swing in all of our rainbows, putting up lots of stuff on the TV screens. And we try to keep stuff up on the TV screens really all year round, our posters about our program and any sort of special events happening.
Another initiative we did was starting off with social media impact on both Instagram and what was formerly known as Twitter. We really want to connect with healthcare providers, researchers, and patients, and trying to give them more resources and let them know that we're here at the Princess Margaret. We were able to establish a global audience with viewers from the United States, United Kingdom, Germany, France, Australia, different parts of South America, and so many more countries. And we're currently at over 590 followers. We've had about over 3,000 views per post, over 140 posts on Instagram. And it's been amazing seeing this continue to grow. However, there has been a lot of challenges, such as sustainability and how time-consuming it can be. Initially, we were doing about 2 posts a week, one called the Monday Challenge, which highlighted different challenges that our SGC patients face to give healthcare providers something to think about while giving patients some affirmations that it's not just them going through this and not just them experiencing it. However, this required a lot of thought and input from our whole team, and it just got to be too much, especially as we started doing more research projects. So just something to keep in mind. As well as some of the controversies that we faced. Starting off, as I mentioned, we used to use Twitter, but due to certain controversies, we started to steer away from that. As well, always just being aware of people known as trolls going on social media, sometimes writing negative things, sometimes not getting the point of what we're trying to say, and just trying to steer through that correctly in the most inclusive way.
Yes, and as we had mentioned to you before, one very clear outcome from our general needs assessment before the specific needs assessment with our patients was that we did an environmental scan and realized there is not really any good educational material available for healthcare providers who, as I say, and we have demonstrated before, have a very big appetite for getting the education in communication skills and strategies on how to communicate about pronouns, gender identity, asking about sexual orientation and relationship diversity, but really there wasn't much out there. So with the help of the Young Leaders program at Princess Margaret and also the Cancer Experience program, to both we are very grateful. We got an initial grant to create an e-learning platform which we call PMChosenFamily CA, and you have the QR code here as well as the URL. So if any of you would like to try out our gamified version of how to interact with an avatar who's going to challenge you a little bit in your inclusivity communication skills, then please try out this platform. It was a lot of work, but also a lot of fun working with many people to get this work done. We won't have the time this time around to show you a demonstration of the program, but when we go to the next slide, you will see that you, in this program at PMChosenFamily CA, will meet 4 different avatars, Chaitan, Lexi, Max, and Ross. All of them are based on consensually shared patient stories, and these patient stories are all centered around pronoun, sexual orientation, gender identity, and relationship diversity. And you're basically having an opportunity to go into a dialogue with these 4 patients, who are all patients with a cancer story. And you will be able to try out different strategies of how to communicate with these 4 patients to give you some space for reflection, but also some playfulness for finding out how it feels for a patient if you're using a really inappropriate form of prompting, and what will happen at which point the patient will actually end the conversation with you because they feel there's no rapport or they feel unsafe with you.
So another initiative we took on, something that we heard a lot, both in the interviews and also when we were reviewing the scripts for that e-learning project, is that even if you ask in the most inclusive manner, patients aren't always going to feel safe to disclose information about their SOGI in these meetings. Sometimes it may be easier to do so over electronic medical records, but previously there wasn't always the opportunity to do this. Recently, UHN went through an overhaul, switching over to EPIC, the new electronic medical record system, and we really pushed for it along with the diversity group at UHN to include different aspects, such as having an opportunity for patients to say both their chosen and legal names in case they haven't been able to change their legal name yet, a place for them to put their pronouns, their sexual orientation, their gender identity and sex at birth, any gender affirmation steps they've taken or that they plan to take, as well as their organ inventory. Christian, anything you'd like to add on to this?
Well, maybe at this point only that taking this step is in so far really exciting and helpful, because one aspect that's problematic for any research on intersectional identities is that most often we lack the very basic data to even show frequencies or statistic relevance to why we're doing the work we're doing. And the most basic problem is that we're not asking for those elements that are important for us to know about. So at this point in time, for example, I would not be able to give a very clear answer to the question of how many sexual and gender diverse patients are actually being treated at Princess Margaret at any given time, or how many patients with a queer identity actually enter the cancer care system in the Greater Toronto area. This is not for lack of interest in the topic, it's simply for lack of recording this kind of information. Yet at the same time, it is also a very sensitive topic that needs to be addressed in a very careful and in the appropriate way, because there needs to be a balance struck between the need to know and also the need to know, namely, when is it not necessary to share information? Jackie Bender is one PI working out of Princess Margaret. She's a wonderful colleague, a wonderful collaborator, and an excellent scientist who is working on a form, the HECT form, that basically tries to create the most possibly inclusive and diverse SOGI form. It includes more than the SOGI information, but basically a form that gives that asks about all information relevant about a person's identity, social denominators, and labels that are relevant for healthcare. However, when this form was tested, they also found in the piloting that some patients didn't feel comfortable sharing very personal information, even if it was by way of a bracket of information, because they were not clear in why this information was relevant to healthcare or cancer care. And so I think what we have to learn and where we have to work with our communities by way of research outreach is to understand better when to ask questions about personal identifiers, how to ask them, and how we can also make sure that the patient retains ownership about this information so it doesn't go distributed everywhere without their consent and their knowing about it.
So to carry on with how we're working towards meeting and addressing the needs of our diverse patient communities, we developed a brochure that provides further information about our program, about the resources that are offered, and patient support. On the right-hand side of the screen is just an example of our little poster that goes up on the digital screens across Princess Margaret and in some of the outpatient clinics. We've also provided some information in the patient family library. So patients are able to borrow books and ebooks and resources that include relevant information and patient stories and experiences. We've done a lot of work on our website with the help of our team, and you can go onto our website and check out the different areas and do a little bit of exploring. One of the things very early on that we heard from healthcare providers was, well, I don't really think I'd ever want to talk about SOGI with patients because what if they ask for resources? I don't know any of the resources. So hearing that from staff, and then also from the literature that was telling us that, a lot of patients have a great deal of difficulty in finding appropriate and supportive, relevant resources. This was one of our first undertakings, was beginning to pull together a patient resource booklet. So it's available on the website. It's going to be updated in June, and there'll be another 30 or so resources added to it. And right now there's just over 200 resources. So it's really valuable. Another thing that I think has helped with patient navigation as well is just trying to be very transparent, just really putting ourselves out there and inviting patients to sort of read about our work and to have a look at our annual report. And we're so thankful to our wonderful patient partners who contribute to so much of our work and really help us.
Here on this slide, you see a big Scan Me QR code for those of you who are interested and motivated. If you go to this QR code, it'll lead you to a Linktree link, which gives you a lot of background information on our work. Again, these slides are going to be available via the recording, and probably also very happy to distribute them afterwards if you want to reach out to the Joint Center for Bioethics. We'll be very happy to share them. With this particular QR code, you get a lot of our background information and the reports that Margot was just referencing.
At Pride, since the end of COVID, last year we did our first in-person patient event, and it was lovely. We met at a park in downtown Toronto that also has a beautiful labyrinth, and it was sort of a wonderful evening of patients sharing some of their talents and their musical talents along with our music therapists, poetry, songs, and experiences and meditation, and then sort of walking the labyrinth by candlelight. So it was really lovely, and it was sort of under the reflecting how Pride can be sort of a time of mixed feelings for many patients. And a time where it can be difficult to go into crowded restaurants and crowded spaces and pubs and all of this sort of rah when you're going through a difficult time. So just sort of acknowledging that, but also sort of bringing together a real sense of healing and community. So it was a very sort of powerful event.
It absolutely was. And as you can all imagine, Margot was our main lead behind organizing this beautiful event. She's an absolute wonderful star when it comes to making sure that we balance our work that goes out into the community also with an inside look into what's going on for ourselves. We're coming to our final slide and just want to be quite excited. Hopefully we're going to have a little bit of Q&A after our talk. And I also really want to address that we would be happy to have a critical conversation. So if anyone has questions around what we're doing, why we're doing it, or is feeling just having a sense of something is not sitting right with them, we would really like to invite them to share their questions with us, because that's what we're here for. And I wanted to just show you on this slide that we in 2022, for the first time within our program, walked at Pride with, well, lots of joy, as you can see, and really investing into joy as one of the GSRD domains. And last year we walked as well, as you can see in 2023. This year in 2024, we have full endorsement of our full organization, which I think is in so far important as all the way back to 2005, 2006, the first grassroots initiatives at UHN had formed and had already walked in smaller numbers at the existing prides, but we didn't really had much organizational buy-in. And over the years and over the work that we've been doing in a place of safety, but also in a real sense of collaboration, we've achieved an organizational and cultural change within UHN that has now brought us to a point where UHN is officially marching as an organization, as a healthcare organization, and a place of healing at Pride 24. So thank you very, very much for having us here today. We really appreciate the invitation. Thanking again, Dr. Gibson and Sue MacRae for having us here today. Thanking everyone in the audience, wherever you are. If it is very late for you, please sign off and go to bed. If you're still here for Q&A, we would love to hear your opinions, your suggestions, your thoughts and questions. And thank you very much for giving sexual and gender diverse patients in cancer care a space so that we could shine the light on their wonderful, wonderful journeys. Thank you all, and looking forward to the Q&A.
Thank you so much. I have to confess that right now, I mean, just when Margot, you were talking about fostering joy, I think this presentation actually, I'm feeling it kind of bubbling here, just feeling some joy surface here. And I just want to say how inspiring the work that you're doing is, and congratulations. I know that it's a labor of joy and love and a tremendous amount of trust that this will be realized. And I also just want to acknowledge too that you were building this during pandemic. So this, I'm imagining that provided an interesting context for your experience. I guess maybe just a moderator's prerogative here. I'd love to just open with one question for you, and I'd love if you might be able to reflect a little bit on the name of the program, Chosen Family. And I, it strikes me, because chosen families, these are the relationships that matter to me. This is my family. They're the ones I want to bring with me during my care journey and my healing journey. And I wonder how this might rub up against a patient's birth family. And this might be not just younger people, but over the life course, as somebody's transitioning, somebody is coming out, or somebody is discovering their gender identity and starting to want to manifest that and express that in their lives, and starting to feel that struggle. I want my family here, but I feel safer with another. And I wonder if you could just reflect a bit more on this a bit, and perhaps even share a little bit about how perhaps families, however defined, may have a place within the program. And I don't want to suggest that they do or they don't. I would love to just open it up for your thoughts and reflections on that.
No, this is a really good question. I mean, I don't know, Margot, Brendan, I'd really like your input on this one as well, but I'll just kick us off with a very short one. One thing, when we came up with the name it was indeed in the middle of the COVID pandemic. And COVID pandemic work in a cancer center did mean that we were, for the longest time, in the unbearable situation of actually having cancer patients who either stayed with us for very long treatments as inpatients, or who unfortunately found themselves not in a survivorship, but in a palliative care situation that sometimes also became an end-of-life care situation. Unfortunately, many of these patients that we cared for did not have an opportunity to have their family members, no matter whether chosen or not, be around them. And I'm aware that many here have direct access to the lived experience of what that actually meant, and how much disenfranchised grief we're still carrying with us today. For minority groups, the COVID pandemic was actually extraordinarily intense. And we do know that in particular in the sexual and gender diverse communities, especially those with intersectional identities, the sense of existential isolation and loneliness was sometimes overbearing. And so when we founded this program, what we realized was that we needed to create a sense of community that felt real. And for many, not everyone, but for many folks who are undergoing identity challenges and questioning, who need to find the courage to find their new own voice, it unfortunately is a reality that it is often, not always, but often, those chosen people in your life who become a substitute for core family. And it is also often the case that unfortunately many do not find something that feels like family, like chosen family. And so what we aimed to address with this label was to create a sense of hope and direction, because much of the despair that we see in the context of psychosocial care for sexual and gender diverse patients has to do with loneliness, has to do with the sense of not being seen within their communities. And so I'll leave it to Margot and Brandon to add to this, but I hope that explained a little bit why we came up with this idea and handle. Margot, any additional thoughts from your end?
Yeah, it's such a great question.
Yeah,
and so much we could say about it.
Yeah.
I love the points you made. The other thing that comes to mind is the importance and the healing. And we're a cancer center, so we're all about sort of healing. but of the importance of those kinds of connections wherever they come from. And we're hoping that we will be able to do some support groups coming up in the future that will hopefully provide even more opportunities for those connections. And a big part, I think, of what our program does too is to help patients and their loved ones and their caregivers and their families to connect with the community. And we're so fortunate to be located in downtown Toronto, and grateful for the privilege of having so many different community resources and ideas that relate to people's interests and possibilities for connection. Yeah, Brendan, anything you want to add?
Yeah, for sure. I definitely agree with everything that Christian and Margot said, and just adding on to it too. I think part of it as well is just our own group, and our own group felt a little isolated at times, and we really became our own chosen family just with our different colleagues, and how much we've grown as a community, you know, doing different holiday events. Margot's always so amazing, handing out Pride gift bags every June, handing out different gift bags at the end of the year, and it really has become a family for us as well. I think too, where you just mentioned sort of the divide between chosen family and family, that's where sometimes it can be important to, you know, ask definitions from certain people, because one thing I've learned is that a lot of people will define things in their own way, and like their chosen family can include their biological family as well. So it really can be different how people will define it, and it can really include everyone.
Yeah, thank you. And I've noticed that the word lonely has come up a few times, both for your own team and then also for the patient going through their journey and feeling lonely. And then during the pandemic, when people were radically just separated from each other in really important ways. And it sort of speaks to this kind of existential suffering that people carry with them. And where does that go? And be able to find a community to hold people together during that time seems so important. I wonder if you might want to say a little bit more about the home of this program within the bigger institution, and how this program is, how it's relating to others, and perhaps is this the beginning of something that can actually, there are going to be diverse patients in any program within UHN, and they're going to jump back and forth between programs and so on. So just wondering about how the institutional uptake has been around this at this stage, keeping in mind it's still early days for the program. It's doing great work in its early days, but what is it like to move something like this forward within a big institution like the one that you are? It's your institutional home. Any sort of advice for folks who might be seeking to do the same in their own spaces?
Yeah, I'll start off. I think a lot of it comes down to the amazing work by Christian and Margot branching out to different departments at UHN and Princess Margaret, doing so many amazing talks and connecting and trying to find whatever opportunities we can to spread the knowledge that we have. We've received amazing uptake from different departments, such as the Department of Supportive Care, Princess Margaret's Cancer Education, different survivorship clinics, and so on. And it really has been amazing seeing how many different groups are asking about us and trying to find out more and trying to learn more. And that's where things like our e-learning website, the PMChosenFamily.ca, sort of came from, is that so many people want this information and knowledge, and we just had to provide an easy way for them all to access it on their own times. We have connected with other groups outside of Princess Margaret as well, such as the UHN Diversity Group, and we hope to do more work with them to, like you said, spread this throughout UHN, because it's not just Princess Margaret that has SUD patients. Margot, would you like to add on to that?
Yeah, I guess, more sort of information and education and reminders and training about inclusive care, it really benefits everybody. And I think in cancer care, we've begun to identify some special populations, like older adults, like AYA programs. I'm trying to think of sort of all the sort of different categories we have now. And our thought was that, and based on our quality improvement project, was that we weren't really wanting, or we weren't imagining that we would be the kind of service that would have a specific SGDC clinic per se. So, for example, like a clinic that every queer person, go to your right and go to the queer clinic, and everybody else go over this way. Instead, I think we want options, and we want to integrate better across all of the clinics. And then for patients who really feel that they want a safer space with staff who identify as being from the community, then that would be an option as well. So that's kind of where we're at. And it is a challenge. We're a great big organization. So there certainly are challenges, but there's also opportunities, and wonderful resources that come with a great big organization. Christian.
I think I'm wondering whether there are any questions from the audience, or whether it is because we often sometimes experience a sense of hesitation for people to bring up questions because no one wants to get it wrong. And I think that's one thing that we are hoping to model as well, as much as we can, is that we're actually not saying it is important to get it right, but it's okay to get it wrong and then get it right in the second time. And that's what we're trying to teach a lot, because part of our e-learning, for example, as well, is not about when you work with the avatars, it's not about getting it right with every little interaction you have with the avatar, but rather we're focusing on how can you engage interpersonally when you notice that something went wrong in the relationship, and how can you repair a relationship when something felt wrong, inappropriate, or maybe just you used the wrong pronoun unintentionally. And so a lot of the program is actually built around learning how to work with repairing relationships and also apologizing in the right way.
Thanks, Christian. And maybe what I'll do is just remind folks that you have the option of putting a question into the YouTube chat, but also you have the option of sending a question anonymously. And so just remind you where you can send the question. You can send it to jcb.ea@utoronto.ca, and I believe that email is in the chat function. So I do invite you to send an anonymous question there. I do know that Sue MacRae does have a question, and so I would like to invite her to. Sue, what's on your mind?
Oh, I'm so moved by your presentation. What I'm aware of is sort of the sort of depth of collaboration and community and curiosity and compassion that comes through is just incredible. Like I'm so drawn to your team. Like I feel like your team sort of reminds me of a team that I'd want to be a part of. It's really, it's wonderful. And so I feel from an inclusivity point of view, like just that way you're all coming together is incredible as a model for teamwork. I think where I went, it's kind of on a different tangent now, like is the theme of loneliness. When I think about having cancer and how like isolating that is, and then adding to what you're sharing with us today, this whole identity isolation really makes me think of institutional trauma that folks come in, like, we know from ACE scores, the adverse childhood events experiences questionnaire, that folks are more likely to have medical conditions like heart disease and cancer and that sort of thing. So we have to assume that some folks are coming in with a cancer diagnosis already with a trauma history, and then we're bringing them into a medical situation, which is traumatic. And then on top of that, there's something interpersonal and relational going on that's traumatic as well. And I know, Brendan, in your description, you said you were interested in trauma-informed care. And I'd just be so interested in like what principles you're working with around that, if any, at this point.
Yeah, that's a great question. I think starting off where we talked about minority stress theory, that's so important. It's thinking about what they're coming to this hospital and what experiences they've already had. Specifically in healthcare, like they could have had so many poor experiences before they even come to Princess Margaret that can possibly lead to them feeling defensive, and that's totally valid and understandable. So really being aware of that and just going the extra mile to try and make patients feel safe, and doing things like uh, just talking about your pronouns right off the bat. In the interviews, certain patients that we had that were patients with Christian and Margot mentioned how important it was to them that Christian and Margot talked about their soji right off the bat, and just how much that meant to them and how much safer they felt just with those little things. And seeing things like the Pride lanyard, seeing things like the environmental indicators in the hospitals can really just change their perception of healthcare despite their past experiences. Christian or Margot, would you like to add on?
Yeah, maybe
Yeah,
oh, go
go
ahead,
ahead.
Christian.
No, Margot, go ahead.
Yeah, I think Brendan raised some really good points. I think too, when I meet a patient for the very first time, I sort of realize how vulnerable they must be sort of feeling. And so I do things that I don't do with other patients. I always introduce myself, as hi, I'm Margot. I'm the social worker with the program. These are my pronouns, and I'd like to share with you that I'm a lesbian, and I really want to acknowledge that sometimes in cancer care, we don't do a very good job in dealing with this whole issue of sexual and gender diversity. So that's why our program is here, is to provide that safe space that's very safe as we can make it, and very collaborative and very sort of transparent. And we really are here to support you in whatever ways that we can. Start right off the bat from that. And that's not kind of our usual way of working with patients.
Thank you. I might want to add as a final comment, we are also very mindful about the fact that when we talk about sexual and gender diversity or queer patients, we need to be very mindful that we are not thinking in a binary way. We have patients who are identified in several dimensions on a non-binary horizon. And those patients, they face very specific kinds of dilemma, because the whole system of healthcare has an ingrained cis heteronormative binary thinking. No one's fault. It is not that anyone does this to create barriers, but the barriers are there nonetheless. And there is a reason for why we have research data that shows that patients who identify, especially on the non-binary and trans identity spectrum, have a much higher likelihood of not living as long as other patients in the general population with similar cancers. So what we're talking about here is not just a matter of perception. It is actually a matter of survival time. It is a matter of survival time with quality of life. And so the work we're trying to do is hopefully in the long run actually going to help to further close that gap, which is an actual measurable gap. But we're also here to make sure that we keep that conversation ongoing. It is a difficult conversation, and I can tell you that we are not always getting it right. Sometimes we have to sit together and think about in case discussions of where did we get it wrong? Where were our unconscious biases? Margot and I sometimes share text messages late at night, thinking about cases and thinking, damn it, I got it wrong. And this kind of learning together is actually extremely helpful, because again, when we can be more vulnerable, we can also feel safer with each other. And when we feel safer, we can collaborate in moving the system forward towards a more inclusive and diverse healthcare experience. Thank you very much for having us.
Oh, I'm so happy. And can I just say one more thing on that point of giving permission? Because as a clinician, I do trauma work as my work now. I'm a psychotherapist. And I would say I get it wrong fairly often, and I keep trying, and it's vulnerable. And it's also, I'm very lucky to have a team of clinicians around me that are very like engaged and wanting to learn and wanting to share and coming together to try to, learn from each other. And I have to say your website with the avatars, that is an extremely novel and very important intervention, and I look forward to sharing that with our hospital and with our program. So thank you so much.
Please do. Yes.
So if I might, I would love to follow one line of inquiry further to build on this. And that is, I think, Margot, I think you mentioned patient partners, and I would love to understand what their role is and how they're, so it seems like it's not just simply because having patient partners is a good thing to do. It seems like core and constitutive, you can't do this except with everyone there. So I wonder if you could just reflect a bit more on how
Sure.
you're working with
Yeah.
patient partners and in what ways, and
Right.
yeah.
Great. Well, we've just been so fortunate to have some wonderful patients be introduced or directed our way. And we've asked some of them if they'd be interested in helping any of the projects that we have on the go. Maybe we're being a little bit of renegades, where we're not sort of following the typical UHN process of patient partners, because it takes a little while. And, often we're working sort of on the fly with tight deadlines. So we just do really try to take advantage of sort of the resources and opportunities that kind of come our way. So our patient partners have been quite a diverse group of experiences, everything from folks who are working and teaching in universities as part of diversity programs to young adults, a whole bunch. I can speak especially to our needs assessment. When we reached out to some of our patients and asked them to have a look at what we had proposed to do, and it was using some standardized questions and scales that were reliable and validated, and all that stuff takes a long time to do, and things get outdated very quickly, the language and so on. So when patients looked at it, they told us very, very clearly and directly that this was not going to fly. This would be such a bad mistake if we went there, that this language was so horrible. It was so disrespectful and insulting. So we had to start from scratch and figure out how we were going to go about doing this. Because of course, if you have patient partners, you have to listen to their very wise words. And we switched around the whole sort of project to be a more qualitative interview process, which took longer, but it was really worth the time because some of the information and data that we've got from that project was amazing. So we absolutely love our patient partners, and hoping that in the future we'll be able to get them to have a more prominent spot on our website to really sort of recognize the wonderful work that they do.
Yeah, it is a point where I also just want to differentiate again. When we talk about collaborations, we have different collaboration partners with different expertises. We have some really established scientists who are working with us. I want to name a few: Jackie Bender, Gila Shapiro, it is Amanda Bolzers, and all of them have really significant understanding of how to construct studies, how to make sure that we get good REB, etc. And all of this is a very, very important. That's the work that they are doing, and it is the research piece that will necessarily, over the course of time, actually then give credit to our program and will show us that the program actually works. But at the same time, the work that's been done in an academic environment, so to speak, also needs to be balanced with a very applied real-world approach to truly listening to those who should be and are at the center of our interest. And this is where I feel that Margot, Brendan, and I, when we first started, and now we have a wonderful executive of 4 people, Margot, Sam, Jennifer Croak, and myself, where we really try to work from a perspective of genuine humility. Yes, we do also have our identities, but we are the bearers of some form of power because we are within the healthcare organization, we're within the cancer centers. It is already a privilege to even find people who want to be interviewed and tell us openly and honestly what they think needs to change. So I think creating a more, if you will, action research frame where we're very much working in the community outreach and letting the community decide for us what our research priorities should be is the approach that we try to take. And that is not easy when you have very little funding and very few resources. But I can tell you that this has made our whole program feel so authentic and emotionally engaging and safe because we are talking about the topics that truly seem to be relevant to our communities. And that feels very empowering and feels like the kind of agency that we're looking for.
Yeah, and just to add on to that, where Margot was saying we had to completely switch up the needs assessment and switch to interviews, then it became challenging because it took so long to find 21 patients. I think we started interviewing patients last October, November. Sorry, actually earlier, I think it was last February, and we finished in December. And it took that long to find 21 patients, but it was worth it just due to how amazing all the feedback was, how amazing these interviews were, and how much insight we gathered from them.
Yeah, I've heard this expression, sometimes you need to go slow to go fast. And I think that really illustrates this, that you need to take the time to build the relationships, to do the listening in order to be able to, and Christian, I really love the word that you ended on, the authentic and safe. So it's that sense of really our humanity or your humanity is fully reflected in everything that you're doing. So just want to congratulate you on a wonderful and an inspiring presentation. Before I do a final farewell and formal thank you. I do want to make a couple of announcements for folks who are online with us today. Our next seminar will be taking place on March 27th as part of our annual JCB Weave lecture series on ethics and governance of AI for health. A little bit of a different direction topic, but I think there's a theme in here that might be really relevant. The lecture will be given by Dr. Barbara Prainsack, who is Professor of Comparative Policy Analysis and head of the research platform and governance of digital practices in the Department of Political Science at the University of Vienna, with discussants Dr. Beth Coleman, who's Associate Professor of Data and Cities at the Institute of Communication, Culture, and Information and Technology in the Faculty of Information at the University of Toronto, and Professor Sarah Nunnally, who's Associate Director of the University of Ottawa Centre for Health Law, Policy, and Ethics. And what they will be discussing is the topic of governing AI. What is data solidarity? So when we think about community and bringing us communities together again, I mean, it's a real shift away from the individual as this person all on their own to actually thinking about solidarity and community in a different sort of way. And so I hope those of you who may be interested in that topic will be able to join us. It will be held both in person and online. And if you'd like to register for that, Terry will put a link to the registration in the chat. If you'd like to hear about the JCB seminar series, you can also send us an email. We'll put you on the mailing list. You can please email jcb.info@utoronto.ca, and Terry will also put that into the chat that you can find. Collaborative specialization in bioethics students enrolled in our interdisciplinary seminar course. Please remember to track your attendance, and I look forward to talking with you about today's seminar, the Sue MacRae seminar, when we gather again next week. But now, now that I have the privilege of saying Christian, Margot, and Brendan, on behalf of all of us, and on behalf of Sue MacRae, who is joining us today, I want to thank you so much for your presentation. For the courage of your work, for the vision of your work, and just really want to hope that you continue, and we'll be watching closely and listening and hopefully learning from the work that you're doing. So thank you so much for joining us today. And thank you everyone who is joining us online. Thank you for joining us as well, either in person, synchronously right now, or viewing this after the fact. So I'll say to all, be well. and we'll look forward to seeing you again soon.